10 years ago, maybe 15 years ago, we were still treating non-small cell lung cancer pretty much as a single disease where everyone was receiving chemotherapy. And then with the discovery of activating mutations in the epidermal growth factor receptor, we began the era of targeted therapies and molecular testing for lung cancer. Over the last decade, and really even just the last few years, there's been an acceleration of this movement where we're now having to test for probably 7 different molecular alterations in patients principally with non-squamous, non-small cell lung cancer or adenocarcinoma of the lung. And it seems to be getting faster and faster. In fact, in May of 2020, we had 2 new approved drugs for both our MET exon 14 mutant non-small cell lung cancer and our RET fusion positive lung cancers. And so the guidelines even have trouble keeping up with this. So the CAP guidelines still recommend EGFR, ALK, and ROS1, even though since 2018, we've had approved drugs for BRAF, V600E mutant lung cancer. And then with the addition of RET and MET, we now have a wide range of available treatments, FDA-approved treatments for different populations of patients with lung cancer. And of course, we can't forget our NTRK fusions, which are very rare, but still have very effective treatments if you identify them. So the major changes that we have now are educating patients about, talking about this with their doctors, educating our oncologists in all of the available treatments and how effective they are. And then, of course, educating everyone on the importance of testing, because if you don't identify these genetic alterations, then it's like the patient doesn't have them, because with standard treatments like chemo and immunotherapy, they don't do any better, and in some cases worse than patients who have wild type non-small cell lung cancer.